Hey, Dr. Dubinskaya, thank you so much for joining me on the Fempower Health podcast today. It's so lovely to have you.
Hi, Georgie. Thank you so much. It's my pleasure to be here.
And now today we are here to talk about rare-ish things that can cause pain with sex. And this is such an important topic because, with Fempower Health, I've recently transitioned to mostly talking about perimenopause and menopause and chronic pelvic pain. And, I feel so honored that many friends now come to me sharing their deepest, darkest secrets. And a lot of it has to do with pain with sex. And I often hear it feels like razor blades, like that is literally what women will say over and over and
Yeah,
over again. And I think it's so important for us to know that it happens and there are ways to fix it. And so I really appreciate you coming here to share your expertise.
absolutely. Yes,
Why don't you first tell us about yourself so that we can get to know you and then we can start talking about this topic?
of course. Yes. So I'm Alexandra Dubinskaya. I'm a board certified OBGYN and fellowship trained urogynecologist and sexual medicine specialist. So in my practice, I see patients who are suffering with conditions of pelvic floor, like urinary incontinence, fecal incontinence, pelvic organ prolapse, pelvic floor dysfunction, interstitial cystitis, chronic UTIs. And also I see patients who has any issues with arousal, desire, orgasm, and also perimenopausal and menopausal patients, because that's usually the predominant group of the patient who likely to have all the pelvic floor conditions and sexual health issues. So that's what I do,
Yep.
and I'm located in Los Angeles, California.
Okay. And can you please tell us what a urogynecologist does? And here's why I say this. One of the
Mhm.
things that I feel so honored is I've had interviewed now over 150 experts in women's health, which I can't believe. I've been able to connect with so many wonderful clinicians who are so passionate about helping women. And there are such interesting subspecialists. And I think as we navigate the healthcare system, I've also realized because it's so complex, we kind of need to be our own advocates because you all are so incredibly busy. And while you try to help us, you can't think of everything, nor can you do everything. And so, why don't you explain to us what this field is? Um, and I think that'll help a lot of women who are trying to find their path forward.
Of course. So urogynecology is the best field in medicine. And you can become a urogynecologist from OBGYN path and then do a fellowship, or you can be a urologist and also do a fellowship and become a urogynecologist. So it's a specialty that takes care of urological issues, gynecological issues, and also we deal with fecal incontinence as well because it's also in the pelvic floor. So it's very sad to me that not so many women know about this field. Not only because we can help a lot of women, but also because I spent significant number of years training, operating every day. So, and it's very sad that not too many people know about this field and search help. So we are the people who help women who who peeing themselves, who has the bulge in the vagina, who have discomfort with sex. And usually what I noticed when I was in my OBGYN residency training, that the moment women stop having kids, they kind of can't find they like the space, they can't find the help in the regular OBGYN office. Because okay, you done having kids, we can remove your uterus, but all other stuff we pretty much cannot do for some reason. And I think there is an issue with our education that we can't fix overnight. But I really like dealing and taking care of the conditions that happens after having kids. And that was one of the reasons why I went into urogynecology. But also at the same time, I noticed that whenever you have pelvic floor disorder, dysfunction, you also develop issue within your sexual life, because that's pelvic floor is one of the very much involved organs in sexual activity most of the time. So it kind of like those issues go hand in hand. And it just made sense for me to learn, to educate myself, to address like both of those conditions.
Mm-hmm. That makes
And
so much sense.
yes, and what happens also, usually like women go to primary care, they refer them to gynecologists for any issue. But when I go and talk to primary care and tell them what I do, I actually see how they like divert their referrals and they refer to me directly, and women actually able to get help sooner,
Okay.
which very nice. So I think spreading the word about urogynecology is very important.
Yeah, no, I agree. And I'll just give you my experience, and I hope this helps women, because this is not just about, and with Fempower Health, like, I know when I originally started, it's like, here's a condition, here's how you fix it. And I feel like there's so much more of a story. It's really, how do you navigate the healthcare system? And that's where I feel like my advocacy work, because I also work in the healthcare system as a consultant, comes in. So from my experience, I did the same thing. So I'm training for this marathon, and I have hypermobility, and I know that with having a child, vaginal delivery, I knew that I had a little bit of a prolapse. I think it was like grade 2. And I didn't seem to have issues, but then running with the marathon training, once I finished my half marathon, I noticed things were just off. And I
Mm-hmm.
was like, I was like, who do I go to? And so I researched, and luckily I found an in-network urogynecologist. And I knew eventually I'd have to go to a pelvic floor PT. And I wasn't even
Mm-hmm.
100% sure the difference between the two. And so my path was, I went to the urogynecologist first. I didn't even like ask my OBGYN. I just went because I knew the OBGYN wouldn't be able to help in a detailed way. And then I've been referred to pelvic floor PT, but because I'm looking for in-network, I'm on a wait list. So what we've done in the meantime is, because I found that I have urge incontinence, and I think stress incontinence, and
Mm-hmm.
the prolapse. And so what we've done is, I now have a pessary, and
Mm-hmm.
it's the one that's also for the incontinence. So it's got the little lip on it, and I love it. And she said it may or may not work. And so what I'm doing is I wear it when I run, or
Mm-hmm.
when I'm playing tennis. So all the intense exercises. And can I tell you, just by wearing it for like the past week or so, I'm noticing a difference even when I'm not wearing it.
That's
So,
amazing.
yeah, so I commend the work that you all do, because it is so important. And so hopefully the people listening who are motivated to be here about pain with sex will also understand. And maybe I'll take a clip of this discussion and put it on social media so people understand. But I think it's so important for us to also understand how to use our doctors.
Absolutely. And you brought up an interesting point of like, oh, who should I see first, like pelvic PT versus urogynecologist? And there is actually not like a right or wrong answer. I think because pelvic PT becoming a little bit more accessible right now, a lot of women go and see them first. And then if they notice that the condition is not getting better, they go and see urogynecologist. But even saying that, it's totally fine to go and see urogynecologist first, who can basically offer you the whole list of available treatment options, and you can pick and choose. And if pelvic PT is something that you would like to try, or let's say pelvic PT and a pessary, it's totally like fine. And some women, they know that they don't have time, they don't have like available like settings for them to do PT or to wear a pessary, and they just want a problem to be fixed. Then urogynecologist would be the best bet, because they can get you for surgery faster.
Right. Right. No, that makes sense. Can I just tell you, because some people on social media, when I shared I did this, were like, but I'm so nervous about, what they're going to do. And can I just tell you, like, I guess because I have no shame. I don't know. I've been doing medical speak for 20 plus years. And so I went in and I was telling people I had to stand on the pee pad and they had to like um, test like my degree of being able to hold urine in or whatever
Uh-huh.
they were testing. And we all just laughed. And then I had to try the pessary on in the office, like putting it in,
Yeah.
taking it out so that everyone was confident that I know how to do it. And it was all women and everyone was so gracious. And we were laughing. I felt like it was like a bunch of best buddies, like trying to like help me like get through this so that I could run a marathon and be healthy. But
I'm just
it
gonna.
was
Mhm.
it was a really, really good experience. And so I will just, a reminder, which I know you've said too, is like these doctors, they don't care if we've shaved, if we haven't, or anything. It's just like you're focused on helping. And it was actually a really funny experience. We just laughed. They thought it was funny too. So because I was laughing. So it was a great experience.
Yeah, and I like to tell my patients, like, remember, I do it for a living. So if you pee over here, that makes my job significantly easier. So just be open-minded.
Yeah, yeah, no, absolutely. Okay, so then now that we've talked about what you do and how, we shouldn't have shame over, and it's okay if you feel ashamed. I guess we should never dismiss feelings, but just know that best, it's a great place to go to get help for things that we may all feel ashamed about, but are things that happen, especially at this time in our lives. So let's talk about these rarish things that can cause pain with sex. I know we kind of put together a couple of categories here around hormone changes, skin conditions, and then this other category where these didn't fit into. So why don't we
Hmm.
talk about the hormone changes first? Because I know, especially with perimenopause and menopause, everyone's talking about hormone
Yeah.
changes and hormone therapy, everything hormones. And I know having a baby changes your hormones, or while you're pregnant, your hormones are changed. If you get a hysterectomy, your hormones are changing. So talk to us about these hormonal changes and these rare-ish causes.
Yeah, we call them rarish because they're not that rare. They're more common than we think. And I think now society kind of accepts those hormonal changes for menopausal women, for perimenopausal women, but we're forgetting about a couple of groups that are very common and can happen at any time. So
Okay.
those groups would be people who's taking oral hormonal contraception pills, because a lot of people taking this medication starting from their teenage years, either it's for the painful periods or they have PCOS, or as a contraception option. But nobody really tells women when they start the pill that that will decrease the amount of the estrogen that you have, the active hormones, the estrogen, the testosterone, and that will affect not only like depression or like you can gain some weight. It can affect your bladder. You might develop urgency and frequency. You can develop vaginal dryness because, again, all the vaginal opening, the urethra, the bladder has abundant amount of the estrogen receptors. So everything that happens in perimenopausal and postmenopausal women, that might happen to women who's taking the oral hormonal contraception pills, especially for significant amount of time. And by significant, I would say 2 years and more, but some women might be more sensitive to that deprivation in the hormonal levels, and they might experience symptoms earlier. So
Okay.
in my practice, I see all the time girls in their mid 20s or early 30s, where they're in a relationship, everything is going well, they're becoming successful in their life, but suddenly sex becoming very painful. They start using more lubrication, they're feeling that only like a certain position can work for them, and then they start avoiding sex because it doesn't feel that good. And it definitely takes toll on them and on the relationship. And they has been like a good patients taking the birth control every day, and we start reviewing all the possible causes for that. We check the blood work and we see how like the estrogen level is almost zero. We see how the sex hormone binding globulin, SHBG for short, that's a special protein in the liver. If you have a lot of that protein, your hormones tend to be inactive. So it binds to your hormones. So the hormones can act on a targeted tissue. So the women who take oral contraception pill, that as sex hormone binding globulin rises. So even a little bit of hormones that you have, they all like not very active because of that protein. So we're starting discussion about stopping birth control, which can be difficult because women being afraid of the endometriosis kicks in, of getting pregnant, and it's not easy to recover from those hormonal changes. So sometimes I actually add hormone replacement therapy, like a little like estrogen patch, like very low dose, and then prepare them for like stopping the birth control. Sometimes we can have to continue taking that estrogen patch a little bit longer. And all the changes that happens to the vaginal tissue, they not always comes back. So it's important to like add some estrogen and testosterone for like external genital area, because again, remember, everything from the hymenal ring outside has a lot of testosterone receptors. So giving some cream that has both estrogen and testosterone, or suppositories like Intrarosa that has DHEA that converts in the body in estrogen, testosterone, can help to heal the tissue, can help, I would say, regrow the clitoris, because among those women, you can see how clitoris gets smaller. And sometimes they can even develop some clitoral adhesions, or the clitoral hood can get fused just because the tissue is so deprived from hormones. So see how often those women just being misdiagnosed for like, oh, you probably have like vaginal infection, let's get a swab, let's presumptively give you some S medication or some BV medication, and that's not the reason why they're having all these symptoms. I wish more women would know about it, and I wish more providers will know about it, because that's not something that we learn again in a OBGYN residency,
Right.
because that's very important. And also, because of all those changes, some women might start experiencing more frequent urinary tract infection, which again, because similar to the postmenopausal women, it changes the pH. It can affect the growth of the bad bacteria, make it a little bit easier for the pathogenic bacteria to get in. So one of the kind of first questions that I ask women who I see in my practice is, are you on the birth control, and what type of birth control?
So,
okay, that's go ahead.
well, can I just ask you, I sound like dying to ask this
Yeah.
question, is, right now there's been so much press around birth control and being terrible, and I guess listening to you, I guess I'm wondering, does every woman have this to some degree? Is this only certain types of women? Is it only certain types of hormonal birth control? Like, for example, I remember I've hit menopause, so birth control is like a long time ago for me. I don't remember but I just know there's like the low dose ones. And so there's like all these different variations, right? And so with the headliners of birth control is evil, let's clarify, based on what you're saying, how we should now view birth control, knowing these very important life-changing side effects.
Yeah, well, bottom line of all the birth control, there is no good birth control out there, unfortunately. So every type of birth control has side effects. Any birth control that affects ovulation will affect your hormones, your own level of hormones. So the low dose of hormonal contraception pill, they still produce the side effects. They still go through the liver. They still trigger the production of that sex hormone binding globulin. And I've seen a lot of women who were taking progestin only pills, and they also lab values in menopausal ranges. And it also brings us to another type of birth control that has been considered to be like very safe and work locally, the IUD, intrauterine devices. Again, in my training, I was taught this: we put this device in the uterus, it produces these hormones locally, and there is no systemic effect. And to be honest, I was telling that to my patient when I was in residency after graduation. But then start noticing, and like, to be total TMI, I had IUD, and I noticed the change, and I'm like, why I feel like I got like significantly older down there? Why I feel drier? Why I get all this like UTIs? What's going on? And then I was listening to my patients, and I checked the blood work of my patients, and their levels being affected, because in some women, the amount of hormones that IUD produces is enough to suppress the ovulation. So it also affects the systemic hormones. And even locally, the production of local hormones can affect the vaginal lining, the amount of lubrication that we produce. So I think we do need to change what we tell women about the IUD, that yes, it's supposed to be a local birth control, but some women might be more sensitive to it, and it still might produce some hormonal changes. And right now, what I actually prepare my patients who just getting IUD, if you notice changes, it's not in your head. Let's see each other. Let's look at your vagina, at your genital area. And if we need, we can add some small dose of local vaginal estrogen so it can balance you out. So it's
Okay.
also an option.
Okay.
Obviously, with IUDs, the effect is a little less compared to like all oral contraception, because the hormone doesn't go through the liver, but this effect is still present.
Wow.
Yes. And some women might say, how about the copper IUD? Because copper IUD doesn't have any hormones. Yes,
Right.
it doesn't have hormones, but it makes your period horrible. Your period gets heavier with clots. A lot of women report pelvic pain. For some people, it works and they're happy with that. But again, there is no perfect birth control, and you kind of have to pick your poison.
Okay. And, I guess woman is experiencing this. I mean, typically we go to the OBGYN for birth control and is experiencing this. Would it be fair to say most OBGYNs aren't trained, and it would be when these women get more significant symptoms, then they end up coming to you? And is there a way, like, if that is the case, how can women advocate for themselves with their OBGYN?
Yeah, well, I respect my colleagues, and I don't think that that's their like personal fault.
Oh, no, of course.
I think the issue is how we trained in residency. I'm advocate for separating OB field and GYN field, because it's a very like two different specialties, two
Yep.
different types of people. Like you can't do it all and be like the best at each field. And the amount of GYN knowledge that we receive in OBGYN residency, I don't think it's sufficient to provide adequate care,
Right.
because it's all kind of, we learn in a way of like dogmas. Birth control, you have to have a birth control. You deliver baby, you have to be on the birth control. You have to discuss about birth control. But how about like learn what other side effects? But it feels like the feeling that I get from the like training and like doing all the modules to keep the certification is there is aggressive push of not having baby. And like, again, undesired pregnancy is the big disaster. You don't want it, you don't wish it for anyone. But I think we need to step back. And right now, especially in our world where majority of women start having families a little later, and we're a little bit more educated about unwanted pregnancy, like talk a little bit more about all the contraception methods from a different standpoint of not like what will prevent you from pregnancy the most, like what are the side effects really, not only like a big side effects of blood clots or like liver failure, all of this like big guns, like something minor that we might not notice initially but can progress to something bigger, like genitourinary changes or like
Right.
sexual, like issues with sexual desire or with orgasm. Like I think it's time to respect and validate that women are sexually active. And same way how urologists ask men about how's your orgasm, how's your erection, we should be able to ask women about that. And if somebody is not able to have orgasm or their desire changed, we shouldn't just tell them go drink some wine or it's because you have like 2 kids. We should
Right.
actually listen and investigate, what are we doing to those women, what medication are they taking that could be triggering this.
Mm-hmm. Right. No, that makes sense. And you know what? One thing I will say, because I've been noticing in my appointments, just because I have the fortune of having interviewed so many of your expert colleagues as well, is even in the appointments, they're actually not an hour long. They're still quick, but it's very focused because it's the right discussion. And I know that has been something that look, granted, to clarify, the pelvic PT one is longer because they had to like get the pee pad out or the urogynecology. They had to do all those little things, but it was still quick. Like it wasn't this like
Yeah.
4-hour discussion. It was still like, here's the check. Here are the questions, but everything's very targeted. And I do feel like if we come in to the appointment and we're very clear of what's happening and we don't miss out and rely on the doctor to happen to ask the right question, I do think the dynamic gets better. I do still think we need to be at the right doctor. But I think it's so important to emphasize, because I feel like sometimes on social media, there's all this medical gaslighting, and I do not dismiss that because it does happen. But I think we kind of have to look in the mirror of like, how much are we like telling our doctor about our needs and struggles, and we don't need appointments in all cases. So I don't know what you think about that.
I agree 100% because your relationship with your doctor is similar to relationship, let's say, like with your partner. If you're just going to say everything is great, like there's no way for them to go in your brain and like read what exactly bothers you. So you do need to be concise of, okay, this is what bothers me. I have like suspicion that like, I don't know, IUD pills can be causing it. Let's talk about it.
Yeah. No, that makes sense. All right. So, summary about contraception and hormonal changes because of that. We are not saying don't take birth control. What we are saying is birth control has side effects that are beyond weight gain, mood changes, blood clots. It can have all sorts of impacts because it affects your hormones and your hormones all over your body. And so we want to make sure that we take that into account and advocate for ourselves. And if we're not able to have the right discussion with our OBGYN, our urogynecologist is our next best friend. Is that a fair summary?
Yes. Yes.
Okay.
And I think there are also, the summary is great. To add to your last point, there is also some gynecologist who specializes on rarish conditions, but they can like treat their like persistent infections or skin conditions. So you can find them. They also would be a good bet.
Okay, great. And then one quick one is genitourinary changes associated with lactation. That was another one. We should cover that.
Yeah, so that's another group of women who unfortunately kind of like being underdiagnosed, because we have a genitourinary syndrome of menopause, right? When the
Right.
women, again, because of their hormonal deprivation, they develop some changes in the genital tract, urinary tract. But when we have a baby, and especially if we're breastfeeding, the amount of estrogen and testosterone is extremely low in our body. So we kind of like postmenopausal women like when we breastfeeding. So, and especially when women breastfeed for a long period of time, they might start feeling the vaginal dryness, discomfort, sex becomes painful. And when you have painful sex, you don't really have any desire to engage in that activity.
Right.
So And it's kind of traditionally been like swept under the rug. Oh, you just had a baby, you have a sleep deprivation, um, just go on vacation, which all those things are true. But it's very important to look in the vagina, to also evaluate that women is breastfeeding. Oh, it's been like 2 years since she has been breastfeeding. So there are obviously going to be some changes. And again, vaginal estrogen, the best friend, very helpful, helps a lot with all the dryness, kind of give back what we're missing. Some women are very anxious about the topical estrogen getting in the milk, which is, even if it gets there, it's extremely small amount because vaginal estrogen is very safe and mostly working topically. The absorption might be a little bit higher in the beginning just because the wall of the vagina is thinner, similar to the postmenopausal women, but as the walls rebuild themselves, the absorption is very like minimal. So it's safe with breastfeeding. But if women are still anxious about it, at least control the symptoms with the vaginal moisturizers, not the lubricants, moisturizers on a daily basis. Also can help. It's not going to treat the cause, but at least relieve the symptoms.
Okay. No, that's very helpful. That's very helpful. So good to know. I mean, it's, I will tell, every time I talk to these experts, I learn like another nuance. I feel like I need AI over all of these nuances and be like, okay, here are the 10,000 things that no one would ever think about that you really need to know. Okay, so let's start with the other first. We'll end with the skin conditions.
Okay.
So one was vaginal cyst. Talk to us about that.
So vaginal cyst. Women who has a vaginal cyst usually see several doctors before they get to the urogynecologist because they GYN, looked in vagina, they see a bulge, they think, okay, that's probably prolapse. But you're young, why would you have a prolapse? You don't need to do anything. And the women usually would have this kind of non-specific symptoms. So I feel discomfort in the vaginal area. Sometimes I have more discharge. Sometimes I have less discharge. Sometimes I feel better after having a lot of discharge. And sex can be uncomfortable. So they can go to urogynecologist. Urogynecologist will do exam and say, hey, you know what? Actually, your bladder is not prolapsed. You don't have a prolapse, but you probably have a cyst. And that cyst is formed when we are babies, when we are embryo. And genitourinary symptoms, kidneys, they formed very closely together. And during that development, some of the changes can happen and the cyst can form. And some women might never have a symptoms. Some women might have a small cyst that they don't even know about and they're not bothered by that. And you just accidentally find it on the exam. And some women might develop like a pretty large cysts that can almost like come through the vagina and drain and cause a lot of discomfort. So in that case scenario, when it happens, you just need to go to operating room, open that vaginal wall, open that cyst, remove all the cyst wall, close it in layers so the cyst doesn't come back.
Okay.
And after that, usually women live their normal life. Majority of cysts do not recur. Sometimes if the piece of the cyst wall left behind, the fluid can reaccumulate. But again, it doesn't happen that often.
Wow. Okay. So, so you described the symptoms. Anything else that women should know about the cyst? I mean, the symptoms seem to be like really clear. And I think when I love hearing the symptoms as well, because sometimes we don't know how to explain what is happening because what's happening with us, because we're with ourselves every day, kind of starts to become normal. And unless it becomes a big deal, you kind of don't notice. At least that I've found that even with myself. And then when I talk to all these wonderful experts, I'm like, oh, now I see what they mean. This is probably something I should take note of. So,
Well, important thing is one of the main differential diagnoses for the vaginal cyst is urethral diverticulum. So
Okay.
urethral diverticulum, it's basically outpouching of the urethra, the tube where we pee from, and that outpouching goes in the surrounding skin of the urethra. So you also kind of have a cyst, but it's in a little bit different location. And the symptoms that you experience with urethral diverticulum are no symptoms, or some urgency and frequency all the time. Sometimes you can have this post-void dribbling when you pee, get up, and a little bit more urine comes out. You may experience frequent urinary tract infections that just can't seem to go away. And also, some women may experience just pain with sex, and that's it. So, when we look at the exam as a physician from like our position, the cysts tend to be a little bit more on the side, and the diverticulum tends to be a little bit more towards the middle. So, the helpful test to differentiate one from another is pelvic MRI, and your provider should make a note what he or she is looking for. Is it urethral diverticulum or the cyst, to make sure that the technologist will run the machine, like run the images like low enough. And on the images, you can see if it's a urethral diverticulum, so it's connected to the urethra, or if it has nothing to do, completely in a different area than your bladder or urethra. In some rare cases, the cyst might be located very close to the urethra, but you can't really see that exact path, that connection. So in that cases, I usually talk to patient and explain to them that the only time when we can differentiate one from another is while we're doing surgery. If I find that connection, then you have the diverticulum, then you have a little bit longer recovery because you have to close the urethra. Or if there is no connection, we just remove the cyst and you're good to go.
Okay. I could imagine women being afraid of having surgery down there. And I'm saying down there, not because I don't want to use the terminology, but I'm like, down there could be many things: the vulva, the vagina, all of those parts. And so, I guess, what would you say to them? Because what I'm hearing you say is it seems like all of this is treatable and they can go back to their life. So I guess, what would you say? And the other thing maybe that would be important is the consequence of doing nothing. That might be an incentive. Yeah.
Well, first thing, if you don't even know that there is a cyst, then you don't need to do anything. Okay. If there is something that keep bothering you, something that brought you to the doctor, then it's reasonable to consider the intervention. The urethral diverticulum, there is a very small chance that the cells inside of that pouch can transform and become cancerous, like long-standing diverticulums. It's very
Ouch.
rare,
Okay.
but it could happen. So with cyst, I'm not very aggressive. If it doesn't bother you, we don't need to do anything. If it bothers you to the point where you can't have sexual life, you can do your normal activities, then it's time to give your life back, remove it, forget it, like move on. If it's urethral diverticulum and you don't have symptoms, it's reasonable to observe, but make sure that you see your urogynecologist on a regular basis, that you kind of like being mindful of all your urinary changes.
Okay.
But if you having persistent symptoms or you keep having urinary tract infection, then I would say it's reasonable to address, remove it, and also go back to normal life.
Yeah. Okay. That's great. That's great. Those are good incentives and good prognosis.
Yeah. And Georgie, another reason I think a lot of women afraid of doing surgeries, and it's not only about the diverticulum or cyst, but also I see it with like prolapse and incontinence, because it's not so well known, that people feel like it's something very rare and only them having it. Because, for example, like nobody really scared about breast augmentation because a lot of people having it. So it's kind of like not normal, but people know that women have those surgeries, they're surviving those surgeries, they're happy. Sometimes they take the implants out, the life continues. But there is no really like a platform or place where women can say like, you know what, I had that surgery, I had this and that, because every condition below the belt is not respected conditions.
Right.
So there is no this like general knowledge that it can happen, we can fix it, and you can move on with your life.
Right.
So I think actually bringing awareness about urogynecology, that women have those conditions, that they're more common that we think, um, can make it a little bit easier for women to make a decision and not be as afraid.
Yep. No, absolutely. Absolutely. Thank you for sharing that. And I will say, and I'm not saying this to scare anyone, but you know, I know that when I first started this podcast, a wonderful woman out of the UK, Luce Brett, had reached out and she wrote a book about her prolapse situation. And it was rough. And she's like still struggling because I think it was misunderstood. The surgeries were bad, like all these things. We've come a long way. But just seeing her impact, I think a lot about that. And that was also why I was so proactive, because I'm like, if it gets worse, it's not great. And, there's so many simple things to do to be proactive about our health, and vulva health, vaginal health, to never get to these awful places. And so I hope that at the very least, people take away from this is like, don't be afraid, see the right doctor and you will get help. And then you just move on with your life. Like, I don't think about it. Like, I have my pessary, no big deal. I'm like, got to go for a run. I put it in. And by the way, I keep forgetting it's there. And I know you're not supposed to wear it at night. And so I'll be like, oh my God, the pessary, got to take it out.
You can wear it at night. Actually, a lot of women who have a poor dexterity or for any reason can't take the pessary out will leave the pessary for 3 months, and
Okay.
it just stays there. And we see women in the clinic take it out, clean it for them, put it back in. So nothing bad going to
Ah,
happen.
okay. Okay. Good to know. Thank you. All right. So now on to the skin conditions. And we could do a high level on these because I think you had mentioned I should interview Jill again. So maybe I'll reach out to her and she'll give us a deep dive. But at least for people to give us a high level of what to expect. Lichen sclerosis and lichen planus or planus. Did I do
Yeah,
the accent on the wrong?
you did perfect. Yes. Well, yes, Jill Krebs is the best person to talk about those conditions really in depth. What I want to say is, usually we have been thinking about lichen sclerosis as a condition of old women,
Okay.
but not too many people know that actually a lot of young girls have lichen sclerosis, but it goes undiagnosed. So a lot of girls who's like kind of like itchy down there, people might think that, oh, she probably has a UTI, taking them to the doctor, but nobody really examines them.
Okay.
They go misdiagnosed, and I can't tell you how many girls, women I saw in my residency when they like about to deliver the baby. I meet them for the first time, right? Somebody else was taking care of them, and I look at the genitalia, and I see how like they totally don't have labia minora. The labia majora looks small. I can't even see the clitoris. And I asked them, hey, has it always been like that? And they like, yeah. I'm like, has anyone talked to you about it? Has anyone biopsied it? Have you tried anything? They were like, no. And this is the woman who has been through the whole like healthcare routine of like being teenagers, probably getting some contraception, getting pregnant, going through like a prenatal care, now delivering the child, and still nobody ever looked at the genital area and asked, hey, has it always been like that?
Wow.
And again, the problem is that in our educational system, nobody tells you, like, okay, you need to look at the vulva. Like, vaginal exam is not only to get a pap smear or try to like locate the ovaries with bimanual exam. It's also about looking at the tissue, looking at how everything like looks to you. And we're not like, there's no norms on how genital area looks, right? Everyone is different. But if you see that something is off, you should ask, hey, has it always been like that? And totally different topic, but the same situation with the female cutting, female genital mutilation. We have a large population, like immigrants from other countries where it's legal. I've seen so many women who had it done during my GYN clinic and residency, and I would just ask them, hey, it's like your clitoris always looked like that? And they would just tell, no, I had that procedure done. But nobody ever asked them. So I think we should normalize talking to women, how the genital looks. And if something looks off, it's totally normal to ask. And going back to lichen sclerosis, sorry,
No, please. I mean, this is what we need.
and so it's very also common in premenarcheal girls. And if it's left untreated, it's going to continue to progress. And
Okay.
what does it mean, progress? So the symptoms of itchiness, discomfort, tearing with sexual activity will persist. And also the changes in architecture of the genitalia will continue to progress. So the most common signs are whitening of the tissue of the vulva, resorption of labia minora, basically disappearance of labia minora.
Oh my
Clitoral
gosh.
hood gets fused, and sometimes it can be fused completely. So you can't even find the clitoris itself because it's all covered.
Oh,
The earlier you start treatment, the more likely you will stop those architectural changes from progressing. Unfortunately, we don't have a cure for lichen sclerosis yet, but we do have the tools to keep women in remission
okay.
or make the recurrences shorter.
Okay.
So for more mature women, right? Let's say that's the first time they're noticing some itchiness. They're noticing that whenever they have sex, it's kind of like a lot of tearing happening. It could be lichen sclerosis. It's very important to see a gynecologist, and sometimes they're not going to look at the skin. So just tell them, hey, I have a itchiness over here and here. Can you look? And the person who sees a lot of this condition, they able to kind of diagnose it just by looking at this. But the gold standard, there is no really gold standard, but confirmation is to do a biopsy. It's
Okay.
not scary. You just take a piece of tissue in the office under local anesthesia so pathologists can actually look and confirm, like, okay, this is
Okay.
lichen sclerosis. And why it's important, because there are many other skin conditions that can look similar. So
Mhm.
if you're questioning it, it's better to have a biopsy.
Okay.
And there are different type of treatments that can be done. One of the most common treatment option is the highly potent steroids that we apply topically. There is another issue is that we have to educate women how to apply steroid. Just little tap all around, not going to do it. You need to make sure that those steroids, they go in the tissue through all the layers. It's really good to soak the tissue before you're applying steroids. So like warm bath or seeds bath or shower. And
Okay.
they apply it, massage it in for like a minute or two. And depending on the stage and the symptoms, the treatment plan would be different.
Okay.
So it's all varies.
Okay.
And some women ask, okay, why I have it? Or like what triggers that? We don't have the answer. There is a multifactorial disease. Part is like autoimmune, part is inflammatory. So that's probably why we still don't really know the perfect cure, and condition keep coming back. But some of the common triggers are stress. So it's important to manage stress. I mean, it's not easy to do, but it's very important. Avoid any scented product, like any like special like intim like wash, or like anything that contains chemicals can trigger the like lichen sclerosis flare. Also, some people might be sensitive to food, but also common is the women who has lichen sclerosis, they usually have other autoimmune conditions like some thyroid issue, some other skin
Wow.
conditions. So it's all comes hand in hand. So if you ever in question, like what's going on down there, and you're the person who tend to have a lot of other additional like non-specific issues, you should see the provider. You should make sure that it's not like lichen sclerosis.
Okay. Wow. Okay. Fascinating. What about lichen planus?
So lichen planus is another type of skin condition, and you can have lichen planus anywhere on your skin, on your mouth, and inside of your vagina. So lichen
Okay.
sclerosis only happens on the skin, but lichen planus also happens on mucous membranes.
Okay.
So sometimes actually dentists are the first who diagnose people with lichen planus because they see the lesion in the mouth. They might biopsy it. And when women has that diagnosis, it actually makes it significantly easier when they start developing some vaginal symptoms to be like, okay, that's probably what's going on. So with lichen planus, the symptoms are itchiness, burning. Sometimes some women might develop even kind of like an ulceration on the vaginal wall, on the like vestibular, which obviously very painful.
Oh, yeah.
Sometimes those lesions can be so undertreated that the vaginal wall can fuse together. So again, what usually happens in real life, women develop those symptoms, they go to general GYN, they being tested for the whole panel of sexual transmitted diseases, they being given Valtrex because it's a common thing to do. If there is a lesion and you don't know what's going on, take Valtrex, maybe it's herpes. Given some Diflucan, some antibiotics, but it's nothing gets better. So they see a couple of more providers until somebody decided to biopsy them, and you can see it on the biopsy. So the treatment also, the steroids, and it also, the regimen depends on the severity, like individual cases. And sometimes those two conditions, lichen sclerosis and lichen planus, can go hand in hand. Women can have both. So I guess the bottom line is, if something doesn't feel right, if you're noticing skin changes, if you're being treated with tons of antibiotics and anti-yeast medication and it's not getting better, just keep trying to see another specialist who can actually biopsy it, look at the walls, and prescribe you the correct treatment.
Okay. Wow. That is incredibly helpful. And it's so nice to know that these can be diagnosed and treated. Obviously, we want cures for everything, and we want, easier diagnostics for a lot of things. But, there's a lot of women's health conditions I've interviewed experts about that are, this one almost feels like the ones you've described are more women struggling because of the way the healthcare system is and finding the right doctor to help them. There are many conditions where we just don't know enough, full stop, like endometriosis. Like we know you need laparoscopic surgery for an official diagnosis, but outside of that, the amount of people I talk to who disagree with each other about all these nuances with endo, then we have that. But it just feels so like straightforward. And it's so interesting to me because what I'm hearing is it's straightforward, but we just need to get to the right doctor.
Yes, and we just the providers just need to look.
Yeah. Oh my gosh. I don't know which is worse, like knowing that it's simple and you're just struggling, or something we just don't have answers to. It's like, welcome to women's health and the healthcare.
Yeah, unfortunately.
I
But
know.
I think because of the people like you, because of the social media, women become more and more aware of all of these rare-ish conditions that's not that rare, and they're able to advocate for themselves. They're able to find the providers who can help them, and I think that what will drive the change.
Yeah, 100%. 100%. So thank you to you and all your colleagues who are on social. What a great job. Like I remember when I met Jill, she didn't have that many followers. I don't even know how many she has now, but I know it's a lot. And by the way, she's so great on social. I remember you guys were doing a social media post at ACOG. She's so great at it. Anything else that you wanted to share? Maybe there's something I didn't ask. I'd love for you to have an opportunity to share that.
I think the most important thing is we women, we have a really good developed gut feeling. So if we know that something is off, something is not right, we should believe and trust that gut feeling. And don't be discouraged if you went to your OBGYN and they just like send you home with this medication for whatever reason it is. Keep trying to find the person who can help you, because again, if something doesn't feel right, you're probably right on that. And there are people who can diagnose and treat, and you can find the right treatment, but unfortunately right now it might take you a little longer to get to the right person.
Yep. No, absolutely. And how would you like people to stay in touch with you?
Please follow me on Instagram. It's Alex Dubinskaya, or my professional account, Dr. Urogyne. You can also send me email to info@drurogyne.com. I'm very responsive, and if there is any questions, so you need any referral or names, because we are very tight group of people who addresses those conditions, so we pretty much know everyone in the United States. So if you need help and you're in the States where you don't know who to like where to go, please reach out. I'm more like than happy to help.
Okay. Thank you so much for your time and your expertise and the care that you give to the women who need it most. I know we all really appreciate it.
Yeah, thank you, Georgie, for having me.